So there's this really fascinating quote by the journalist H.L. Mencken. He wrote, as the arteries grow hard, the heart grows soft.
Oh, yeah. I love that quote. It's, this very poetic idea about aging and empathy.
Right, exactly. And it kind of reminds me of The Wizard of Oz, too. When the Tin Man is told, like, hearts will never be practical until they are made unbreakable.
Yeah, we totally use the heart as this ultimate metaphor, right, for emotion for the human soul. But from a purely biological standpoint, that unbreakable machine the Tin Man wanted.
Yeah.
The human heart is an engineering marvel that honestly makes our most advanced man-made pumps look like, rudimentary toys.
Which is exactly what we're going to unpack for you today.
Yeah.
Because for this deep dive, we've gathered this massive stack of high-yield medical review notes.
Oh, yeah. The really dense ones?
Yeah, exactly. The jargon-heavy documents that medical students use to just cram the anatomy and physiology and, the pathology of the cardiovascular system
Yeah.
into their brains right before board exams.
And look, those notes can be notoriously dry. I mean, they're basically just endless lists of formulas and anatomical diagrams designed for rote memorization.
Right. But we are entirely stripping away the exam prep panic here.
Yeah.
We're here to extract the pure fascination hiding inside those pages for you.
Absolutely.
So think of this deep dive as sort of the ultimate user's manual for the engine sitting inside your chest right now.
Yeah.
We're going to explore how this pump is built from scratch, how it manages its own internal plumbing, and its electrical grids.
And even how doctors can literally just listen to the fluid dynamics inside your chest to know exactly what's going wrong.
It's wild. But to really understand how this pump handles its massive daily workload, I guess we have to start long before it ever even looks like a heart, right?
Yeah, we do. Because the blueprint of how it forms in the womb, well, it dictates how it functions and how it sometimes fails for the rest of your life.
Incredible. The heart is actually the very first functional organ to develop in a vertebrate embryo.
Yeah, it starts beating spontaneously at just like 4 to 5 weeks of development.
Which is so early.
Yeah.
But it doesn't start as that familiar four-chambered structure we all kind of picture, right? It just starts
Yeah.
as a straight tube.
Exactly, just a simple pulsating primary heart tube. And to transform into those 4 distinct chambers, that tube undergoes this truly bizarre process. It's called cardiac looping.
Cardiac looping.
Yeah, it literally twists and contorts and folds in on itself to establish your left-right polarity.
It's basically performing biological origami.
That is a perfect way to describe it. And that left-right asymmetry, it isn't just random. It's driven by this highly specific, microscopic motor protein called left-right dynin.
Okay, so a tiny motor protein is driving the folding.
Right, and what happens if there's a genetic defect in that tiny protein motor, which is a condition known as Cardigan syndrome, by the way, is that the heart tube loses its spatial awareness.
Oh, wow.
Yeah, it can actually loop the entirely wrong way.
Wait, meaning the heart develops on the completely wrong side of the chest?
Yes. The medical term is dextrocardia. Your heart ends up pointing toward your right arm instead of your left.
That is wild.
All because a single microscopic protein failed to push a tiny embryonic tube in the right direction during week 4 of your development.
Just a single protein. Wow.
Yeah.
But, okay, even assuming the tube folds correctly, the internal plumbing of a fetus is completely alien compared to an adult.
Oh, totally.
Like if we think of the fetal heart like a house under construction, the main water line, the lungs, hasn't been hooked up to the street yet.
Right, because a fetus isn't breathing air, so pumping gallons of blood to the lungs to pick up oxygen would just be a complete waste of energy.
Because the mother's placenta is doing all the heavy lifting, right?
Uh-huh.
Out of the oxygenated blood.
Exactly. And because of this, the fetal heart relies on a highly specialized series of temporary plumbing bypasses.
They're called shunts, yeah.
Yep, shunts. They exist to basically skip the lungs almost entirely.
Okay, let's actually trace a drop of that blood. The sources outline 3 main shunts.
Yeah.
So first, oxygen-rich blood comes in from the mother and hits the ductus venosus, which is a bypass pipe that lets it skip the liver.
Right.
Then that blood arrives at the right atrium of the heart. Now, in an adult, that blood would drop down to the right ventricle to be pumped out to the lungs, right?
Right. That's the normal adult path.
But here, it shoots straight across to the left side of the heart through a physical hole. A literal hole called the foramen oval.
Yeah, it's essentially a shortcut door between the two upper chambers. But inevitably, some blood does slip down into the right ventricle.
Okay.
And when the heart squeezes and pushes that blood out toward the lungs, it gets intercepted by a third shunt.
Ah, right.
This one is a little connecting vessel called the ductus arteriosus, which catches that diverted blood and dumps it safely into the descending aorta, totally bypassing the lungs again.
It's a brilliant temporary setup. But hold on, if I'm visualizing this correctly, just the physical act of a baby crying and expanding its lungs for the very first time, does that single breath permanently rewire the internal plumbing of the heart,
It does.
just from air pressure?
Well, it doesn't just rewire it, it violently slams doors shut. It is honestly one of the most dramatic physiological shifts in human biology.
Oh, wow.
Yeah, when that baby takes its first breath, the lungs suddenly inflate like balloons. And this causes a massive, immediate drop in resistance within the pulmonary blood vessel.
Okay, so suddenly all that blood in the right side of the heart has somewhere to go,
Exactly, it rushes into the newly opened lungs.
which means all that blood comes rushing back into the left side of the heart, right? Dramatically spiking the pressure in the left atrium.
You got it. And that sudden, immense pressure differential pushes against the flap of that shortcut door, the foramen oval,
Yeah.
and physically slams it shut.
That's incredible.
And the fluid pressure simply holds it closed until it eventually fuses to the muscular wall, leaving behind just a closed indentation called the fossa ovalis.
Okay, I totally get how fluid pressure can snap a literal flap shut between two chambers. But what about that third bypass pipe on the outside of the heart, the ductus arteriosus? Pressure alone can't just pinch a sturdy blood vessel shut, can it?
No, you're right, it requires a chemical trigger.
Okay.
So, with that first breath, the oxygen levels in the baby's blood shoot up. And simultaneously, because the baby had just been separated from the placenta, the levels of a chemical compound called prostaglandins plummet.
Prostaglandins.
Right, yeah. And it's that specific combination, high oxygen and low prostaglandins, that signals the muscular wall of the ductus arteriosus to clamp down, spasm, and permanently seal itself off.
Which brings us to this truly fascinating medical hack mentioned in the notes. There's a condition called patent ductus arteriosus, or PDA.
Right, where that temporary pipe stays open when it shouldn't.
Exactly. And if a premature baby has this issue, doctors don't necessarily have to do surgery, do they? They can just give the baby a common NSAI, like indomethacin.
That's right, because NSAIDs fundamentally block the production of prostaglandins. So by administering the drug, you are chemically forcing the pipe to close.
That's brilliant.
It really is. And conversely, if a baby is born with a severe structural heart defect and they actually need that bypass pipe to stay open just to survive until surgery.
Oh, wait, doctors will intervene by giving them artificial prostaglandins.
Exactly. They administer prostaglandins to physically prop the vessel open. It perfectly illustrates how much of cardiology is simply manipulating the chemical levers that control these physical structures.
Right. So, okay, those fetal bypass pipes slam shut. But now that all the blood is suddenly being forced into this newly minted, mature, four-chambered pump,
Yeah.
how does the physical architecture actually handle that new, massive workload?
Well, first we have to understand the spatial real estate of the chest cavity. The heart isn't oriented straight up and down like, a Valentine's Day drawing.
Right.
It's tilted and rotated. The right ventricle is the most anterior part of the heart, meaning it sits right up against the front of your sternum.
Which makes it incredibly vulnerable.
Yeah.
Like, if you're in a high-speed car crash and your chest hits the steering wheel, the right ventricle is the chamber absorbing the brunt of that blunt force trauma.
Exactly. And on the flip side, the left atrium is the most posterior part of the heart. It sits all the way in the back, directly pressing up against your esophagus, and a really crucial nerve called the recurrent laryngeal nerve.
Which leads to one of those bizarre aha moments in anatomy. There is a condition called Ortner syndrome.
Yeah, that's a wild one.
Let's say a patient goes to their doctor complaining that they're having trouble swallowing their food, or, they have a chronic hoarse voice. The doctor might look at their throat, but the root cause is actually in their chest.
Right. Because if the left atrium becomes enlarged, maybe the valve below it is stiff and blood is backing up, that chamber physically balloons backward.
Oh, wow.
It literally compresses the esophagus, causing the swallowing difficulty, or it pinches that recurrent laryngeal nerve, which controls the vocal cords, and that causes the hoarseness.
It really emphasizes how tightly packed the organs are. A
Yeah,
structural shift of just a few millimeters in the heart causes a cascade of problems elsewhere.
absolutely.
But let's move from the physical placement to the actual physics of the pump, because the notes introduce cardiac output, which relies heavily on a measurement called stroke volume.
Yes. Stroke volume is the exact amount of blood the heart ejects with one single beat. And it's governed by three primary physical variables: preload, afterload, and contractility.
Okay, to make those variables a bit more concrete for you listening, let's think of the heart like pulling back a slingshot.
I like that analogy.
Yeah. So preload is how far you stretch the rubber band back before you let go. In the heart, preload is the volume of blood filling the chamber, which physically stretches the cardiac muscle fibers right before they squeeze.
And this brings us to the Starling curve, which is a total cornerstone principle of cardiac physiology. Starling's law dictates that the force of a heartbeat's contraction is directly proportional to how much that muscle fiber is stretched at the end of its filling phase.
So just like your rubber band, the more you stretch it with incoming blood up to a certain physiological limit, of course, the harder it's going to snap back.
Exactly. So preload is the stretch, then you have afterload.
Right. And if you stick to the slingshot, afterload isn't the rubber band, it's the wind resistance or like the sheer weight of the rock you're trying to launch.
Yes. For the heart, afterload is the pressure in the arteries that the ventricle has to push against to force the blood out of the chamber. If a patient has chronic high blood pressure, their afterload is constantly high.
Meaning their left ventricle has to work significantly harder just to push the exit valve open against that heavy resistance.
Right. And if the heart has to push against that heavy rock for years, it compensates by bulking up. The muscle wall gets thicker, which is called hypertrophy.
It's like a bodybuilder lifting heavy weights. But in the heart, getting thicker actually makes the chamber stiffer, smaller, and less efficient over time.
Exactly. It's not a good thing. And lastly, we have contractility.
Right. In the slingshot analogy, this is the inherent quality of the rubber band itself. Is it a brand new, snappy rubber band, or is it old, degraded, and weak?
It's the intrinsic squeezing power of the muscle tissue, completely independent of the stretch or the resistance. You can increase contractility with adrenaline during a workout, or it can be permanently decreased if the muscle tissue dies during a heart attack.
Okay, so I follow the physics of the pump moving gallons of blood every hour. But here's something I really want to push back on.
Oh, sure. What is it?
Well, the notes heavily emphasize that the heart feeds itself oxygen using tiny little vessels on the outside called coronary arteries. But if the internal chambers of the heart are quite literally filled to the brim with highly oxygenated blood all day long, why on earth does it need a separate external plumbing system?
It seems redundant, right?
Yeah. Why can't the muscle just absorb the oxygen directly from the gallons of blood inside its own chambers?
It comes down to the strict limits of cellular diffusion. See, the wall of the left ventricle is incredibly thick, dense, hardworking muscle. Oxygen can only passively diffuse through a few microscopic layers of cells.
Oh, I see.
Yeah, the blood inside the chamber is moving far too fast, and the muscular wall is simply too thick for the oxygen to soak all the way through to nourish the outer layers.
So it requires a totally dedicated delivery service. The coronary arteries wrap around the exterior and dive deep into the tissue.
Yep. And here is a totally fascinating quirk of fluid dynamics. Unlike every other organ in your body, which receives maximum blood flow when the heart actively squeezes, the heart muscle itself gets its maximum blood supply when it is relaxed.
Wait, really? During diastole?
Yes. When the left ventricle actively contracts, it squeezes with such immense force that it temporarily compresses and pinches its own coronary arteries completely shut. It's only when the muscle relaxes in early diastole that the arteries open up and blood can rush in to feed the tissue.
Which suddenly makes a racing heart rate look very dangerous. Because if your heart is beating too fast, you spend significantly less time in that relaxation phase. Which means the heart gets less time to feed itself precisely when it's working its absolute hardest.
Exactly. That mismatch in supply and demand is a recipe for ischemia, or lack of oxygen. The notes point out that the left anterior descending artery, the LAD, is the most commonly blocked vessel.
Right.
It supplies the massive front wall of the left ventricle, which is why a blockage there is often referred to colloquially as the widowmaker.
Man. So pushing blood out against heavy resistance creates immense pressure, and, well, pressure creates turbulence. Which brings us to the acoustics.
The sounds.
Yeah. When a doctor presses a stethoscope to your chest, They aren't performing some vague medical ritual. They are physically listening to fluid dynamics.
They are listening to the mechanical valves slamming shut. A healthy heart makes a crisp lub-dub sound, known clinically as S1 and S2.
Right.
Lub is the sound of the mitral and tricuspid valves closing, preventing blood from going backward into the upper chambers. And dub is the aortic and pulmonary valves closing after the blood is ejected.
But doctors are really hunting for the abnormal sounds, right? Specifically S3 and S4, which happen between the lub and the dub. The notes describe S3 occurring in early diastole, right after the dub, and it sounds like a low-pitched splash.
Yeah, imagine taking a bucket of water and dumping it into a swimming pool that is already completely full.
Okay.
If a patient's heart is failing, the ventricle becomes dilated and floppy and it doesn't pump efficiently, so there's too much blood left over after the squeeze.
Ah, I see.
When the new blood rushes in for the next beat, it crashes into that stagnant leftover blood, creating this low-pitched reverberation against the floppy wall.
Although, interestingly, the sources say an S3 splash can actually be totally normal in young athletes or pregnant women simply because they naturally have massively increased blood volumes moving through a very compliant heart.
Exactly. S4, however, is almost never normal. It happens at the very end of diastole, right before the next lub. This is the sound of the upper chamber forcefully kicking blood into a stiff, non-compliant ventricular wall.
It's like the acoustic difference between water hitting a trampoline versus water hitting solid concrete.
That's a great way to put it, and it's often the direct result of that chronic high blood pressure we discussed earlier, where the heart muscle has hypertrophied and lost its natural elasticity.
Okay, so beyond those extra beats, you have murmurs. If you go back to a plumbing analogy, murmurs are basically what happens when you mess with a running garden hose. Like if you put your thumb halfway over the nozzle of a hose, you create a high-pressure, noisy, turbulent spray.
Right. That is stenosis, a valve that has become calcified and stiff and simply won't open all the way.
Ouch.
Yeah, aortic stenosis, for example, creates a harsh crescendo-decrescendo murmur. The sound gets louder and then softer as the blood forcefully, violently squeezes its way through the narrow opening.
And because it's so physically difficult to get the blood out of the heart, the pulse you eventually feel down in your wrist is weak and delayed, right?
Yes.
The notes use the phrase pulsus parvus et tardus, small and late. And then the other garden hose issue is a leaky faucet. Like you turn the handle off, but water still drips backward.
That is regurgitation, a valve that just won't close tightly. Or, you might encounter something like mitral valve prolapse, which has a very distinct acoustic signature.
The clicking, right?
Yeah, the valve leaflets basically bulge backward into the upper chamber like a parachute suddenly catching the wind, and the tethering cords snap taut. It literally makes a sharp clicking sound mid-beat.
Wow. And remember that fetal shunt we talked about earlier, the ductus arteriosus?
Oh, yeah.
If that pipe stays open into adulthood, the pressure difference between the aorta and the pulmonary artery creates a continuous, loud, machine-like murmur that you can hear through the entire cardiac cycle.
Yeah, the PDA murmur.
But here's the part of the physical exam that absolutely blows my mind. The doctor doesn't just listen passively. If they tell you to squat down during an exam, they aren't just checking your knee flexibility, are they?
No, not at all.
They're using your body to run a real-time physics experiment.
It is a dynamic diagnostic maneuver. When you squat down, you are instantly kinking the major arteries in your legs and squeezing the veins.
Okay.
This forces a sudden rush of blood back to your heart, drastically increasing your preload, and simultaneously makes it much harder for the heart to pump blood out into those kinked leg arteries, drastically increasing your afterload.
You are intentionally stretching the slingshot further back and instantly making the rock heavier.
Exactly. And altering those volumes changes the intensity of different murmurs, allowing the doctor to isolate exactly which valve is failing based purely on how the sound changes when you move.
That is amazing.
Or, they might ask you to perform the Valsalva maneuver bearing down hard like you're trying to pop your ears on an airplane. That increases the pressure inside your chest cavity, which temporarily clamps down on the veins and prevents blood from returning to the heart, severely decreasing preload.
It's basically like playing the human cardiovascular system, like a wind instrument.
Yeah.
But, knowing the physics and the acoustics is really only half the battle. Because none of this plumbing works if the pump doesn't know when to squeeze. That requires an electrical grid.
A highly coordinated, specialized electrical pathway that acts as the heart's internal remote control. It all begins at the top, in the right atrium, at the sinoatrial, or SA node. That is your body's natural pacemaker.
And the electrical signal fires and sweeps across the top chambers, telling them to contract. Then the signal hits a roadblock, right? The atrioventricular, or AV node, which sits squarely at the junction between the top and bottom chambers.
Right.
From there, the signal travels down the center of the heart through the bundle of His and branches out into the Purkinje fibers to wrap around the heavy bottom ventricles.
And the speed of that electrical conduction varies wildly depending on the tissue. The signal moves lightning fast through the Purkinje fibers to ensure the massive bottom ventricles squeeze uniformly. But when the signal hits that AV node in the middle, it slows down to an absolute crawl.
The notes say the AV node intentionally delays the electrical signal by about 100 milliseconds, which to me is like an air traffic controller purposely holding a massive jet on the runway to avoid a catastrophic mid-air collision.
Exactly.
If the top chambers and the bottom chambers squeezed at the exact same millisecond, they would just be fighting each other.
Right. That fraction of a second delay gives the top chambers the necessary time to finish squeezing their payload of blood down into the ventricles before the ventricles fire. When you feel your heart pounding in your chest during a workout, that rhythmic, alternating thud is entirely governed by that tiny 100 millisecond electrical pause.
That is so cool. But the electrical pulse itself, the action potential, is uniquely tailored for the heart too. Like, if you compare a cardiac muscle cell to a skeletal muscle cell in your bicep, they have to operate differently to keep you alive.
Oh, fundamentally differently.
Right. If you want to hold a heavy box, your bicep muscle receives a rapid-fire sequence of electrical signals that causes the muscle to lock up in a sustained, unyielding contraction. It tetanizes.
And tetanizing is perfect for holding a box. But if your heart muscle tetanizes and locks up in a sustained contraction, it stops acting like a pump. You die.
Yeah, that would be bad.
Very bad. The heart absolutely must relax to fill with blood again.
So how does the cellular wiring prevent the heart from cramping up permanently like that?
It basically alters the shape of its electrical signal. Cardiac action potentials features something called a phase 2 plateau.
Okay.
In a normal nerve cell, an electrical spike goes straight up and straight down. But in the heart, right after the initial electrical spike, specialized voltage-gated calcium channels open up and positively charged calcium rushes into the cell.
Gotcha.
This inward rush of calcium perfectly balances out the potassium that is flowing out of the cell.
Oh, so it's the equivalent of the cell pressing its foot on the gas pedal and the brake pedal at the exact same time.
Yes. It forces a mandatory electrical plateau. This plateau artificially extends the refractory period, which is the window of time where the muscle tissue is completely immune to being stimulated again. It forces the heart to take a breath, literally ensuring a rhythmic contraction and relaxation, rendering a sustained fatal cramp impossible.
Nature is incredibly smart. And your brain actually oversees this whole electrical grid using remote sensors. The notes detail baroreceptors, which are essentially pressure sensors located in the arch of your aorta and up in the carotid sinus in your neck.
Right. They constantly monitor the physical stretch of your blood vessels. If your blood pressure drops, say you stand up way too fast, the stretch on those vessels decreases. The baroreceptors fire fewer signals.
And the brain interprets this silence as a crisis, realizes pressure is dangerously low, and immediately triggers your sympathetic nervous system.
Exactly. Dumping adrenaline to increase your heart rate and constrict your blood vessels to keep you from passing out.
But the reverse is true too, which leads to something called carotid sinus hypersensitivity. And if I'm understanding this mechanism correctly, applying external pressure to your neck actually tricks your brain into thinking your internal blood pressure is skyrocketing.
Yes. In a person with a hypersensitive reflex, often older adults or someone with stiff atherosclerotic arteries, applying pressure to that specific spot in the neck tricks the sensors. The brain panics, thinking blood pressure is dangerously high.
So the brain just slams on the brakes.
It sends a massive parasympathetic signal straight to the AV node, radically extending that 100 millisecond delay we just talked about. It causes severe bradycardia, a massive drop in heart rate. Blood flow to the brain plummets, and the person faints. Syncope. So yes, the spy movie trope of taking someone out by pressing on their neck has a very real basis in autonomic physiology. Something as simple as shaving too aggressively over the carotid artery or wearing a very tight necktie can actually trigger this reflex and cause someone to pass out.
It is truly incredible how responsive the system is. I mean, we've traced this organ from a microscopic, spontaneously beating tube at 4 weeks of embryological development, performing origami to twist itself into a 4-chambered pump.
Yeah.
We've seen how it violently reroutes its own plumbing with the baby's first breath, how it balances the physics of preload and afterload, and how it manages a highly coordinated electrical grid with built-in safety pauses just to keep us alive.
It is an autonomous marvel, but it is also in constant systemic dialogue with the rest of the body. For instance, the notes mention atrial natriuretic peptide, or ANP.
Oh, right.
If the heart feels that its upper chambers are being stretched too much by excessive fluid volume, the heart muscle itself secretes this hormone.
So the heart acts as its own endocrine gland.
It does. ANP travels through the bloodstream down to the kidneys and essentially tells them to open the floodgates. It forces the kidneys to excrete sodium and water, reducing the body's total blood volume and relieving the stretch on the heart's walls. The pump uses a chemical messenger to tell the body's filters to drain themselves, just to make its own mechanical job easier.
And that profound chemical feedback loop raises an incredible question about the future of medicine, I think. Because for decades, cardiology has been deeply mechanical. We treat the heart like a broken car engine. We install synthetic valves. We insert metal stents to prop open blocked pipes. We implant battery-powered pacemakers. We basically treat it with hardware.
Right, but if our cardiovascular system is this incredibly responsive to chemical feedback loops, hormones, and precise genetic blueprints like the left-right dyning we saw in the embryo, it really begs the question of where cardiology goes next. Instead of replacing a valve with titanium, what if we focus on hacking the heart's own cellular memory? Can we use targeted proteins or genetic therapies to trigger the heart to regenerate its own tissue or heal its own electrical pathways, the exact same way it originally built itself from a tiny tube?
It completely reframes how we think about the organ. We've mapped the mechanics perfectly. The next frontier is learning to speak the heart's chemical language. And, really brings us back to that H.L. Mencken quote. As the arteries grow hard, the heart grows soft. Maybe the ultimate way to keep the heart from failing isn't by forcing it to be an unbreakable mechanical pump like the Tin Man wanted, but by deeply understanding the subtle, fluid ways it adapts, communicates, and maybe one day heals itself. Keep pondering that, and we'll catch you on the next deep dive.